Sorry about that technical glitch. My name is Raksheeth, and I will be presenting the refractive outcomes of toric phakic intraocular lens implantation in keratoconus. I do not have any financial interests. So we do know that among the patients who come in seeking refractive surgery, keratoconus patients make up anywhere between 1 and more than 10%, again, depending on the geographical location and the diagnostic criteria. And we do know that cross-linking, while effective at halting keratoconus progression, the mainstay of visual rehabilitation in these patients is often limited largely to the realm of glasses and contact lenses. Now, while you can do a cross-linking along with the topo-guided photorefractive keratectomy or an intracorneal ring segment implantation, that would facilitate corneal regularization, spectacle independence is never the goal of these procedures. And then enters toric phakic intraocular lens implantation, which is a potential option that could address the keratoconus patient's desire for spectacle independence. So the purpose of our study was to describe the refractive outcomes of toric phakic intraocular lens implantation in stable keratoconus. This was a retrospective case series in which patients underwent either toric ICL or toric IPCL implantation over a 5-year period at our center at Coimbatore. Patients who were included were those with stable keratoconus, either age stabilized or post cross-linking, with a minimum follow-up of 1 year after the surgery. So again, these patients, the way they were selected was if they had good best spectacle corrected vision in a central cone, they were either subject to just a cross-linking or a cross-linking along with topo-guided PRK. And if they had poor best spectacle corrected visual acuity, the cornea was regularized using an intracorneal rig segment along with cross-linking. And we waited for at least 6 months before taking these patients up for toric phakic intraocular lens implantation. So it was an EMR-based retrospective chart review where we got all this data in the post-operative period, and the statistical analysis was by the IBM statistical software. These were the results. There were 126 eyes, roughly equal between the two genders. More than 3/4 had bilateral lens implantation. The mean age was nearly 30 years, and the corrected distance visual acuity was about 2030. And the mean spherical equivalent in this patient group was about 6.5 diopters, and the mean Kmax was about 53.5 diopters. So 3/4 of the patients underwent some form of cross-linking for stabilization. The rest were age stabilized. And the IPCL was used in 62% and the ICL in 38%. The cone was centered in nearly 3/4 of the cases and decentered in the rest. And an astigmatism of more than 4 diopters, 4 or more diopters was seen in 54% of the patients. So the postoperative spherical equivalent was within half a diopters in 80% of the cases and within 1 diopter in 90% of the cases. There was, of course, an improvement when the preoperative corrected vision was compared to the postoperative uncorrected visual acuity. 39% of the patients had a visual gain of 1 or more lines after the surgery that they did not have before the surgery. When we compared specific groups like the ones with low versus high astigmatism, a cutoff of 4 diopters, there seemed to be no difference in the improvement in visual acuity among these two groups. And there were no differences seen again between the ICL and IPCL groups. And there were no statistically significant differences when the visual outcomes of patients with central versus decentered cones were compared. So the results in our study again mirror some of that in literature with similar good results with good visual improvement in these patients post toric phakic intraocular lens implantation. So to conclude, an appropriate case selection is very vital in this patient group, and it is best to only stick with patients who are satisfied with their best spectacle corrected visual acuity. Of course, sizing, as is a bugbear with the phakic intraocular lens procedure in general, does have a few pertinent aspects to discuss with respect to keratoconus, although that data is not in the scope of this study. That's something we're looking into because sizing can often go awry in these cases if we don't take the proper consideration, especially in patients with very high Ks. Again, it's best to avoid this procedure if the patient is used to using specialty contact lenses and is happy using rigid gas permeable or gross K or scleral lenses. It's best to really stay away from this because they are not going to get visual acuity that is going to equal in terms of quality what you will get with a phakic IOL. And it's probably best to stay away with patients who with the best spectacle corrected visual acuity of worse than 612 even after a regularization. And if the patient is simply not happy with the quality of vision with glasses, then you can be fairly certain that this is a patient who is not going to be happy after a toric phakic intraocular lens implantation. I yield the rest of my time. Thank you. Thank you for the opportunity.
I have a question for you. Am I heard?
Yeah. Yes, yeah, you're audible to me, but probably not to
See,
the.
we tend to go for a one size less in these phakic IOLs. So, do you think by sizing the lens a little smaller, in this series, you had any patient who had a rotation of the lens which needed to be realigned on axis?
We did have some patients. We had 6 patients who had some alignment issues that we need to go and fix on day one. As you mentioned, in terms of the sizing itself causing problems in terms of rotational stability if it was sized too less. This was less seen with us. We had more patients who had a higher vault because the lens was oversized. Possibly in cases with K max of higher than 53, 55, and you could have an artificially higher AC depth that shows up, you might end up ordering a lens that is probably a size higher. And this could be something to consider. There are no guidelines that are written down that you need to undersize by this much, and I think it's just based on experience that or pretty much educated guessing where the lens selection in these patients needs to be done.
Or is it that the IPCL, ICL, you noticed the difference?
IPCL is said to have a larger, higher mid-peripheral vault. So even a patient with a lower vault, the tendency of the IPCL itself is not to have the optic coming in contact with the crystalline lens or not being too close. With the ICL, you don't have the same kind of design, but we didn't really find differences in terms of vaulting, at least in the patients in our study, and we didn't really follow any specific guidelines to correct for this, except if the patient had a K of higher than 55, we probably undersized by 0.25, but that was arbitrary and not followed for all the patients.
Okay, what was the youngest, what was the age, lowest age of the patient that you
I
did?
think the youngest age was 22,
And the oldest?
was 40.
40. Because the keratoconus anyway stabilizes after about 27, 28
right.
years of age.
That's why in a significant minority of our patients, 1/4, we didn't go ahead with cross-linking, even though at the time the trend was that if you're going to go in for something to correct, you would not want the cornea to shift in power by chance if at all the patient had progression. But later on we realized that most of this keratoconus just stays quite the same. So it's okay to go ahead and do it even without doing a cross-linking.
And what is your follow-up of those younger patients between 22 to 25?
So
The duration?
this has about 1 to 3 years of data. We're still following up these patients who are coming in. This was a minimum follow-up of 1 year that we have. All these patients are doing well.
Okay, thank you.
Thank you.
And one more question. After cross-linking, why did you keep 1 year time only?
Yeah, so what literature describes is actually for stable keratoconus, they say 2 years without any surgical after surgical intervention is to be considered. These guidelines are again arbitrary. So even the 6 to 12 month cutoff that we had, initially we were following 9 months, then we brought it down to 6 months. We didn't see any progression that happened after the phakic intraocular lens implantation in these cases. So it is an arbitrary number. It's not based on any studies. And that's how the rest of the studies have done it as well. 6 to 12 months broadly is the period.
Okay,
Thank you.